Welcome to BW Healthcare World's Thursday Thought Leaders. My name is Harbinder Narula, and my guest today is Dr. H. Sudarshan Ballal, who is a distinguished nephrologist and is currently the chairperson of Manipal Hospitals. As a nephrologist, he's got a vast experience of more than 34 years, where he specialized in cases like peritoneal dialysis, chronic kidney diseases, acute kidney disorders, renal biopsy, acute renal failures, ureteroscopy, etc. Let's speak to Dr. Ballal on his role at Manipal Hospitals as a chairperson as well as a practicing nephrologist. Dr. Ballal, welcome to BW Healthcare World. Thank you for taking out time to be with us today. And Dr. Ballal, let me begin by asking you something that has been close to your heart. You've been speaking about it, the concept of marginal thinking. How do you think this concept has helped India sail through the recent pandemic challenge?
Thank you very much for having me here. That's a very, very important question because we learn from history and our preparedness from the history. The unprecedented, devastating COVID pandemic left a trail of death, destruction, and misery for all of us, more so for people in the healthcare sector, something that we had never witnessed in the last 5 decades of my practice. However, it gave us huge insights into the future of medicine and the right example of marginal thinking, so to speak. Here is that our extra efforts at promoting digital health, remote monitoring, home care, daycare, and freeing up of inpatient beds and future pandemic preparedness, I'm sure, will go a long way in significant and viable management of healthcare in the future.
Right. And, Dr. Ballal, everyone talks about private-public partnerships as the possible solution to create healthcare access and deliveries in our country. I'm sure we have come a long way, but there still seems like a lot of work needs to happen to create synergies between the private and the public domain. What are some of the challenges in the PPP model in India that you have observed?
Now, I think the PPP has been the mantra for a long, long time. However, it was more of in conversation rather than actual implementation. So everyone uses PPP sometimes in a very loose form. However, the PPP model that was almost forced on us during the pandemic stood us in good stead in many areas, including digital health, when we worked together to oversee care of patients during the pandemic. To give you an example, the Karnataka government came up with a model where all the district headquarter hospitals were connected to private hospitals, including ours. And we had our team in Bangalore directing all the district hospitals. And with this one measure of meeting the doctors there on a regular basis with the experts in Bangalore in the private sector, we saved thousands of lives, no new investment, just sort of teleconsultation and exchange of ideas of how to manage a given patient. And that has put us in very good stead, and it gave a huge boost to digital health and telemedicine. Because for years together, before the COVID pandemic, telemedicine was in a quagmire of regulatory and legal issues. But I can tell you, in the 1 week of the last week of March 2020, all that changed. And it was approved, and now it's a common factor. Of course, during the COVID, most of our consultations were teleconsultations. Now there's a good mixture between teleconsultation and physical consultation. So that was one area where we saw a huge improvement. Of course, diagnostic facilities, COVID care at home, COVID care centers, vaccination were on other areas where the government and the private sector worked together. And I must admit that this is probably the first time in recent times that I have seen where private hospitals have dedicated sometimes 80% of their beds, sometimes entire hospitals for care of patients with COVID at a very, very nominal fee. And I think there cannot be any better example of a PPP model than what happened during COVID. And certainly we need to further refine and look at PPP in running primary preventive care together at the PHC and the Taluka hospitals, because right now it's totally the domain of the government. And I think that's one area where we could certainly look at some kind of a partnership between the private and the government. And we could certainly use the medical colleges. As you're aware, we have close to 700 medical colleges, more than the number of districts in India. And each district headquarters hospital and a medical college can tie up together and adopt some of the PHCs so that we can run it in a more efficient and better manner.
That's absolutely right. You're spot on when you say the COVID, the pandemic actually taught us the acceptance and acknowledging the benefits of technology. We've seen teleconsulting as a technology being available to us for over a decade, but there was very little acceptance, not just from the patients, but even from the practitioners. And I think
Absolutely.
COVID actually changed the game, where everyone at us, our senior age also started using Zoom, etc., to bring efficiencies to our practice. That's a brilliant point. Now, as a business leader, Dr. Bilal, we look forward to the budget every year because that kind of defines the growth that we could expect in the coming fiscal year. Now, do you think that the current fiscal allocations for healthcare in India are sufficient for a long-term development that we look for in healthcare? What is your opinion on this?
Again, as much as the dark clouds of Corona caused tremendous amount of misery and devastation to all of us, there were some silver linings, and one silver lining we already spoke about, that is the use of technology in medicine. The other silver lining I saw was that for the first time in many, many years, all governments across the globe felt that healthcare was probably the most important factor in how strong your country is. It's not just your financial status, it's not your defense, it's not where you're located, but it's how strong the health sector is. And fortunately for us, India did quite well in spite of the challenges we had. And for the first time, I saw that in 2021, the budget took healthcare as one of their pillars in the budgetary allocation. And there was a significant increase in the allocation for healthcare. This was certainly a great silver lining, and this would not have happened but for COVID. I think COVID alerted both the citizens in general and the government to the fact that we have to improve and allocate more money for healthcare. We still have a long way to go. We currently have about 2% allocation of our GDP for healthcare. In my opinion, that would probably should go to 4 to 5% over the next few years. It cannot happen overnight because there are obviously other priorities too. But 4 to 5% allocation in the future is something we should look at.
You're absolutely right in terms of silver lining at the budget. Plus, also, it has brought to attention in this year the importance that the government has focused on, the mental well-being as well. So these were things which were ignored in the past, but I think the government recognizes these things as also a part of making a healthy nation. Now, since we are talking of pandemics, Dr. Bilal, there are, apart from what we've seen as COVID being a pandemic, there have been slow pandemics which have already been there, gradually building up and eating away our population. So are slow pandemics still a threat in India when it comes to long-term goals, things like diabetes, BP, liver? Where are we on these?
I think you have raised a very important point, a distinction between the pandemic of communicable diseases, is like what we saw with COVID, other viral illnesses, so on and so forth. And certainly, we cannot ignore the pandemic of lifestyle diseases or non-communicable diseases. Very honestly, before the COVID pandemic hit us, we were focusing a fair amount on non-communicable diseases or lifestyle diseases, as we call it. And in fact, the mortality from these were more than mortality from communicable diseases, even in a country like developing country like India. So we cannot ignore one for the sake of the other. So I think we should be future prepared for both the pandemics, the pandemic of communicable disease, because I'm sure COVID is not the last pandemic we'll see among infectious viruses or other illnesses. And diabetes, hypertension, obesity, heart disease, cancer are still growing. So I think we have to be prepared both for the onslaught of uh, communicable diseases and non-communicable diseases in the future. Rigorous surveillance, robust public health measures to prevent and manage both the communicable and non-communicable pandemic of the future is what we need to do.
And Dr. Bilal, we are living in a nation where there's a huge gap between the number of doctors that we need versus what we have today. And healthcare education in India, while is affordable, the number of seats for the affordable category are very, very low. So we are facing a challenge of healthcare education in India not being affordable and accessible. What do you think needs to happen in this area? How can we bridge the gap? How can education sector play a role uh, to create a balance between the quality and quantity, keeping in mind we still have a huge gap to fill?
You have brought up a very interesting point about medical education and the sort of the shortage of doctors. However, tremendous work has happened in the last few years. We now have close to 700 medical colleges coming up with about 100,000 undergraduates, maybe 60,000 postgraduates. And we are the largest producers of, so to speak, doctors in the world. And interesting, the current data suggests that we are not short of doctors. We have reached the WHO standards of patient doctor ratio or the doctor patient ratio. However, what we really need to look at is the inequitable distribution of doctors. If you look at Chhattisgarh versus Karnataka, we have a glut of doctors in Bangalore, but we have a tremendous shortage of doctors in many of the underserved areas. So certainly there is a need to increase the number of doctors and more importantly, make medical education less expensive. Now, one of the things we have suggested to the government, and which I'm sure they're acting on, the infrastructure needed to start a medical college is huge. In the good olden days, you needed 25 acres of land. If you need 25 acres of land in Mumbai or Bangalore, that itself will be over 2,000 or 3,000 crores. So there's no way you can cut down the cost of medical college. That is being changed. They have cut down on the amount of land needed. And we should certainly look at having shared infrastructure. For instance, if there are 4 or 5 medical colleges in the city of Bangalore, why should all of them have departments of anatomy, physiology, pharmacology, so on and so forth? We could have a common shared platform for 4 medical colleges so that we can stagger the staff, stagger the timings, and that would be a huge reduction in the cost of medical education. Because now it's very expensive to open a medical college. Even in a non-tier 1 city, it costs hundreds of crores. And unless that is brought down, someone has to pay for this, either the private sector or the government. So if the cost of starting a medical college is so high, you cannot subsidize medical education too much. So one is we need to reduce the cost of starting a medical college, and multiple suggestions have been given to the government. And fortunately, many of them are going to be implemented. We also need to look at how do we support the economically needy in going through medical colleges. And my suggestion would be we should seriously look at student loans and scholarships for the bright, as is being done in the US. In the US, most medical students take a student loan to finish their medical college. Even their parents don't support them. Unfortunately, that is not happening to a large extent in India, but that's something we should start. And setting up of more government medical colleges where the cost of medical education is far less is something we would suggest. And the government has done this very seriously. There almost have 1 medical college for every district, and in some districts more than 1 medical college. So we are slowly going in that direction, but still have some time to reach there.
And Dr. Bilal, do you think that India needs or should consider foreign investment in medical education in India? I mean, is it time that Harvard should come and set up and partner with institutions and set up colleges?
I have mixed feelings about this because we have set up close to 700 medical colleges. We produce the largest number of doctors in the world without any foreign investment so far. We certainly should aspire to have a Harvard or a Stanford here, but certainly I don't think that is the fundamental requirement. I think we should certainly have institutes of eminence. We are very happy that Manipal University or MAHE is one of the institutes of eminence in the country. we need to aspire for that, and some kind of a tie-up with Harvard, Stanford, or whichever you want to look at is something we should have. But I'm not really sure we need foreign investment to set up more medical colleges. We have done very well without foreign investment in medical education.
Right. And Dr. Ballal, we have recently been termed as the pharma manufacturing hub for the world. So where there's a lot of outsourcing activity in terms of manufacturing medicines is happening in India. How can India become a hub for healthcare delivery to the world?
And I think that raises a very important issue. We produce so many doctors every year. We have the largest number of medical colleges. Why should we not be the medical education and healthcare hub for the world? Like Ukraine used to be the grain basket for the world. And we have certainly done that in the IT industry. And I think we should certainly look at that. And what is interesting is there is a huge opportunity for doctors in our country now. Everything that is available in the West is available here at a fraction of the cost for the patient. And the remuneration for doctors is quite reasonable. And interestingly, in the last many years, I have seen the so-called reverse brain drain. I interview a lot of people who are trained in the US, UK, Australia, who want to come back. Certainly, the situation is very different. When I was doing my undergraduate and postgraduate studies, for anything more than a cold cough or a minor illness, people would rush to the UK, USA, or if you're in a smaller town, to places like Mumbai, Vellore, Chennai. However, now we have everything that these centers have in most of the cities in India. So I think we have done very well. And I always tell my youngsters, you study in India, go abroad, get some training, but please come back like what I did.
That's amazing. But Dr. Ballal, when I look at the doctors overseas, I completely agree with you. There's a reverse brain drain that is happening. People are willing to come back to India. We are offering similar salaries, if not better, to many of the doctors. But what about the working conditions of these doctors? I mean, when you look at the senior doctors in the US, the time they have between balancing their personal and professional life versus the schedules that we look at some of the senior doctors in the country, do you think something needs to happen in terms of providing the similar work style, work atmosphere to them in India?
See, I think very honestly, at least I'm talking about the private sector, the senior doctors by and large can dictate the kind of lifestyle they have. I would call this lack of work-life balance as a self-inflicted wound. If the doctors want to spend some time with the family, I'm sure we can make arrangements for that. And we should look at group practices, sharing your responsibilities, so that not every doctor in the group has to come every Sunday, every weekend to see the patients. You have a good group. You have a group that's committed to patient care who can sort of gel with each other. Then obviously you can have a good work-life balance. In fact, at Manipal Hospital, when I first came, the first thing I set up was a group practice. We now in Bangalore alone have about 25 or 30 nephrologists in our group. And the work is divided based on the need. And there is some time for everyone to spend time with their family at home. But unfortunately, the concept of group practice has not yet settled in a big way. I think there is still a fear that patients might go to the other doctor, or the other doctor might take your patients away. So I feel this is self-inflicted, and we have a solution for it.
Beautiful point, Dr. Ballal. I didn't think of this. Dr. Ballal, you spoke about the inequitable spread of doctors. So you have doctors who are trying to, like you just mentioned, retain their patients and own the patient, while we don't have these services available in the rural areas. What, in your opinion, is something that needs to happen to provide equitable healthcare services and access to rural parts of the country?
As I mentioned earlier, while we achieved the number of doctors needed for the country, and both at the undergraduate level and also in work in progress for the postgraduate sectors, there is a huge inequitable distribution of doctors. Just to give you an example, in Bangalore, many of the postgraduate seats and super specialty seats in many areas like cardiology, neurosurgery, neurology go vacant. People don't want to take them. Whereas there is a shortage of cardiologists, neurologists, and neurosurgeons in non-metros or semi-urban areas. So obviously, we are producing enough doctors, but they don't go to the peripheries. Now, what we need to do for this is one is, of course, the digital health platforms have to some extent bridge the gap between expertise available in the cities and rural areas. What we need to do is we really need to uplift the standards of the rural areas. No one, any profession for that matter, maybe lawyers, doctors, engineers, architects, no one will want to go to a rural area which has nothing else for them to take care of their families. I mean, should be overall economic development, connectivity, social life for any professional to move to a village or a rural area. And unless that happens, there will always be a disconnect between the cities and the rural areas. So I think slowly what we have seen, at least in my field and many other fields, is that once there is a saturation in the cities, people percolate down. When I first came to Bangalore, almost all the nephrologists were only in Bangalore. I would say 90%. But now practically every district has enough number of nephrologists. And that has happened because Bangalore, which had 6 nephrologists when I came, now has 200. So obviously there's no room for more. So they will go down to the smaller cities and towns. And that percolation will happen as and when the cities get saturated. Meanwhile, I think the government has to work on improving the connectivity, infrastructure, and elevation of poverty in the rural areas, which obviously will attract more and more people in every field, not just the medical field.
And Dr. Ballal, we are living in a country where there's still a lot of out-of-pocket expense when it comes to healthcare. And, while the penetration of insurance is increasing, the challenge is that not many of the people are, adequately insured. Where do you think we as an healthcare industry are moving? What is the future on this?
This is probably one of the most important parts in the delivery of healthcare. When I first came and started practice here 30 years ago, about 90% of my patients were self-pay, out-of-pocket expenditure, almost 90%. Then, of course, in the recent past, it's been coming down. And currently, it's around 50%. But that's still not good enough. In the Western world, it's in the range of 10 to 20%. We still have a long way to go for universal health insurance. I think a robust universal health insurance with the participation of the government, private insurance, and the healthcare givers is the only way forward. Because I tell every one of my patients that if there was no insurance like Medicare in the US or NHS in the UK, patients would be bankrupt in no time. And that is the honest truth. So if you have to pay for your medical care in the US, even a millionaire will be bankrupt in no time. So I think we have to work together in coming up with a universal health insurance that's viable, both the healthcare deliverer and the patient and the provider.
Very true, sir. When we let me ask you a very important question, and nobody better than you can answer this. What do you think? Who makes a better healthcare leader for an institution? Is it a doctor or is it a management professional? Is there an advantage that a doctor has?
That's $1 million question, really, because I have seen it from all angles. My personal opinion is that though doctors have great clinical acumen and insights into the clinical aspects of healthcare, many of them are not astute businessmen because that's not taught in medical schools, and may not have the financial background, the operational experience to run large organizations. And hence, doctors being at the helm of affairs with a strong support from non-medical operational finance and HR teams would be the best combination. And I must say that Manipal, we have been fortunate to have that. We have had a very good support from the non-medical team, and of course, I have been here for the last many years. So I think that kind of a combination would be the best combination. A doctor at the helm so that the clinical affairs can be looked at, and a strong support team to support the other aspects of healthcare.
Brilliant, brilliant. Dr. Ballal, you're a nephrologist. Now, I want to ask you from the clinician's point of view, how has technology advancement, we've been talking about artificial intelligence, remote monitoring has become a reality, IoT is there. How's it helping the kidney patients, especially those who undergo kidney transplants, etc., which is a really tough situation.
No, I think we already talked about the role of artificial intelligence, digital health, so on and so forth, which applies to all branches of medicine, including nephrology. But certain things are very specific for nephrology. We have had very many modifications in renal replacement therapies in the last many years. If you looked at a dialysis patient about 30 years ago, from a mile you could identify this patient as being on dialysis. Cachectic, malnourished, unable to walk, and looked very sallow. But now a well-dialyzed patient, thanks to the technology and the ways we do dialysis with the renal replacement machines, you can barely say this patient is a patient at all. They are doctors, businessmen, politicians, technocrats. And if they have good dialysis, they're almost as good as normal patients. And this is thanks to the technology where we are able to deliver safe, effective dialysis through the multiple modifications that have happened in the machines that we use, the replacement fluids that we use, the dialysis filters that we use, so on and so forth. And of course, in the field of surgery, if you had to have a kidney removed, let's say 15, 20 years ago, you'd have a 1 foot long scar, maybe stay in the hospital for 2 or 3 weeks, and you would have a hernia after that because you have cut most of your muscle in the abdomen. Now, with keyhole surgeries, laparoscopic surgery, robotic surgeries, things are very different. You can go home in the next day or two for most surgeries, hardly any scar, safe, more efficient. So I think huge advances in the field of surgery too. And we have had many, many different molecules that have come up in the treatment of kidney diseases, both for kidney diseases of various kinds and in the treatment of post-transplant patients, and of course in the treatment of kidney cancer. So we certainly have come a long way as far as technology and improvement in the medicines we have. However, our aim should be not only to have technology for medical care, it should be affordable to the common man. And that's where we are a step behind. I think the technology comes at a fairly significant cost to most people.
Right. And Dr. Ballal, you mentioned that when you came back to Bangalore city, there were 6 nephrologists. And now there may be about 200 or even more. The technology has advanced. We have well-equipped hospitals. And even while healthcare is expensive, we are still more affordable when we compare ourselves to the global costs for delivering healthcare. And which is why today there's a reverse thing where people who are suffering from various conditions come to India. Now, how is medical tourism poised when we look at nephrology and other renal treatments?
Medical tourism or the medical value traveler is something that obviously all hospitals in India and the country as a whole should look for, because that is obviously something that's deliverable, because we have state-of-the-art medical care in most fields of medicine. We do that at about 5 to 10% of the cost of the US or UK. And there's no reason why people should not come to India for their medical care, whether it is nephrology or heart disease, cancer, so on and so forth. It's happening to a large extent, but we still have room for improvement. I believe a concerted effort to publicize the state-of-the-art medical facilities offering care at a very low cost with equivalent outcomes of the Western world should be publicized in the countries where there is a waiting list. In the NHS, and you have a 6-month waiting period to get a cataract, maybe a 6-month waiting period to get your gallbladder removed. Whereas in India, you come, the next day your procedure is done, and a week you're back home at a fraction of the cost. In fact, I do have a lot of patients who come from the US for minor procedures where the waiting period is 3 to 4 months. They come here, they can fly in business class, get their procedure done, go back, and still not spend as much money as they would have spent in the US. But the difference is that there the Medicare pays for it. They may or may not pay for it if the treatment is given outside of the country. So we should actually, the government and the private sector should work together in attracting patients, because the people need to be aware that India has these facilities. They're state-of-the-art facilities. They are safe. The quality of care is excellent. The outcomes are similar to what's happening in their own countries. And that is what needs to be done. And that is where a lot of work needs to be done. For instance, Singapore and Thailand, they advertise medical tourism through the government. And the government sort of helps medical tourism. And I think here the government and the sectors that provide medical value tourism to the patients from abroad should work together. And this should be made known to the people who need treatment, safe treatment, early treatment, cost-effective treatment with the same results.
I kind of agree with you. And in fact, I think this is where the role of the government is very, very critical in terms of making this access, easy access to anyone who wishes to receive quality healthcare at an affordable price by coming to India.
No, it's really, truly important that we provide the ease of travel, connectivity, infrastructure, most of which is in the government's hands, to the patients who come here. They should not get bogged down in the traffic of Mumbai or Bangalore once they come here for medical care and not able to go to the hospital. So I think it should be an overall development rather than just getting the patient to the hospital.
Got it. And Dr. Ballal, you came to Manipal Hospitals as a doctor. And over the last many years, your journey has brought you to lead the institution. Now, how has Manipal Hospital Group evolved, or how do you see it has evolved in the last decades that you have been associated with it? And both in terms of revenue, in terms of size, in terms of manpower, and the value that you bring to the patients.
My journey with Manipal has been a pretty long one, as I had mentioned earlier. I started as a student in 1970, then was a pure clinician between the 1990s and 2010, after which, during which period I also had a stint in the US and came back when we started our flagship hospital in Bangalore. Then I have been on the board for almost 12 years and I have been the chairman for the last 7 years or so. So I have a deep knowledge of healthcare, both from a clinician and administrative perspective. And I've been able to take a very balanced view of running healthcare organization from all angles. Over the last few decades, what I've noticed is that healthcare has moved from individual doctor, family-run, smaller hospitals to professionally managed corporate healthcare chains with huge investments in providing state-of-the-art skilled healthcare to our citizens. Growth through new projects, acquisitions, and consolidations seems to be the new mantra. This is the change I've seen over the last many years. I think that's happening in many fields, from pop and mom stores to malls with all kinds of shopping. So also there is a lot of consolidation, mergers and acquisitions in the healthcare industry.
And Dr. Ballal, how big is Manipal Hospitals Group right now?
We have 29 hospitals in 16 cities with 8,300 beds and still growing.
Awesome. And Dr. Ballal, one thing that I've observed while being in the healthcare industry is that a lot of innovations happen at Manipal Hospitals. This is one institution which has been focusing on doing things differently, whether it is continual healthcare beyond the hospital, through remote monitoring, partnering with devices, companies, etc. What is it that we can see coming out in the next 1 year? What is the innovation that is going to be coming out of the Manipal Hospitals as an institution in the coming times?
We have always believed in having a state-of-the-art infrastructure for our doctors to deliver the best of healthcare, and also put patients at ease. We were the first one, starting from many, many years ago. We were one of the first to start MRIs in Karnataka. We were the first one to get lithotripsy into Karnataka. We were the first one to get robotic surgery in Karnataka. We were the first to do a cadaver transplantation in Karnataka. There are so many new things that we have started. And in addition to everything that you mentioned about innovation, we also focus quite significantly on training doctors. In fact, education, medical education is something that is very close to us. And you would be surprised to know that Manipal Hospitals, apart from Manipal University or MAHE, trains one of the largest number of postgraduates in the country in a private hospital. At Manipal Hospital, where I am in Bangalore, we have close to 200 postgraduates in different fields of medicine and surgery. And we have about 50 or so DNB programs which train students. And I believe that is very important. So innovation in technology, getting highly skilled doctors, training more doctors is what we at Manipal look at.
And what is your personal vision for Manipal Hospitals when you look at the future of what Manipal Hospitals will be or could be?
Of course, we are looking at significant growth through acquisitions, greenfield, brownfield projects, mergers, and we are planning on adding quite a few beds in the next few years. I will not get into the specifics of where and when. And these would predominantly be in the underserved areas of the country and an extension of the existing areas we are already in. However, as much as we would like to maintain the trajectory of our growth and expansion, we would like not to compromise on our basic principles of clinical excellence, patient centricity, and ethical practice of medicine.
This has been such a wonderful conversation. And I love the points that you brought out. For example, the role of PPP that can be there as a contribution towards primary and preventive healthcare. And, the thought of turning the medical colleges into, them adopting to become the PHCs. That's a brilliant solution to bringing quality healthcare to where it is really needed. And, and also the thought behind India being the hub for medical education is something that, if it turns out to be a reality, it could be a game changer in terms of presenting India on a world map for something that can not just change India, but the world. Dr. Ballal, I thank you so much for taking out time to speak with us at BW Healthcare World. It's been a pleasure.
Thank you. It's been my pleasure. And I must tell you that Manipal Group was the first one to start a PPP model in medical education in 1953.
Wow.
Our medical college in Mangalore had a government district hospital as its training center. The government Wenlock Hospital and Kasturba Medical College, in my opinion, was the first private-public partnership in medical education in this country.
Good work always shows and helps you scale. And that's Manipal is a classic example of that.
Thank you very much. It was a great pleasure and an honor to interact with you. We'll keep in touch.